Okay, so Chapter 10 is the anatomic considerations for local anesthesia administration. To be completely honest, it's a little bit difficult to do this chapter without a model of a skull in front of me and without showing you guys these anatomic landmarks in person, but we're going to do the best that we can, and then I'll try to find videos for you guys to help compensate for that. Once we get back into person, we will be able to go over this with you more in depth, but there's a lot of pictures, a lot of help in your book, and then a lot of help from online that you can look at too. Okay. So what we are aiming to do in this chapter is locate and identify the skull bones that are relevant to the administration of local anesthesia, along with the importance of the trigeminal nerve in relation to the administration. We're going to look at the branches of the trigeminal nerve and discuss the importance of the facial nerve as well. And then we're going to look at identify and trace the routes of the blood vessels in the head and neck that are relevant to the administration as well. Starting off with the introduction, so it's important for us as hygienists, or anybody really that is giving injections, to have a thorough understanding of the relevant regions of the skull and the trigeminal, and also the facial nerves, as well as all of the adjacent structures, because the management of pain and the hemostatic control through local anesthesia, that's going to require anatomic considerations. So just to kind of point out the orofacial skull bones, this is just kind of terms of vocabulary. So a process, keep in mind, is a general term for any prominence located on the bony surface. So a condyle usually is going to be involved in the joints, and a tuberosity is going to be a large, often rough prominence. Whenever you hear the word line, think of a small straight ridge. Notch is going to be an indentation at the edge of the bone. Fossa is going to be a deeper depression on a bony surface. A foramen, which you're going to hear a lot, especially in local anesthesia, is going to be a short window-like opening in the bone. And a canal is going to be a longer, narrow tube-like opening in a bone. Another opening is a fissure, which is often a narrow cleft-like opening. So this is the maxilla. It shows the anterior view with all of its bony articulations. The upper jaw consists of two maxilla, which are going to be fused together at the suture right here, the intermaxillary suture, and it's going to each maxilla is going to consist of a body and four processes. So the four processes are going to be the frontal, zygomatic, palatine, and alveolar process. Okay. This is going to show a pano and then the significant landmarks, which you can see here. I know you guys have identified all of these in a pano before, but I want to point out again to you the maxillary tuberosity. That's going to be an important landmark for the PSA, or posterior superior alveolar injection. The next part of this is showing the lateral aspect of the skull. What I want to point out here with the significant landmarks is the infraorbital foramen. There's an injection called an IO, or an infraorbital injection, which this would be the landmark for that. I also want to point out here the posterior superior alveolar foramina, which is here, and that's significant for an injection called the PSA, which is the posterior superior alveolar injection. That's going to be the significant landmark there, along with the maxillary tuberosity. Another one is the canine eminence. This canine fossa here, canine eminence, these are important landmarks for what's called the anterior superior alveolar, or ASA injection. Okay. This next one shows the maxilla and the hard palate. The The landmarks here that I want you to take away is the incisive foramen. You should know where that is along, again, with the maxillary tuberosity. The palatine bone. This picture shows the posterior view of the right palatine bone with, again, its location highlighted in this view here. And so this sort of just shows the posterior oblique view of this. And I guess the significance here is that the palatine bone serves as a link between the maxilla and the sphenoid bone in which they articulate, in addition to articulating each other. Okay. With the hard palate here, this is going to show the inferior view of the hard palate, and there are two main foramina in each of the palatine bones. We have the greater palatine foramen here and the lesser here, which are going to be significant landmarks for injections as well. Make sure that you know where those foramens are. This shows the mandible that's highlighted, and I know that you guys have seen the mandible before. You know what it looks like, but you're gonna. I think after taking local anesthesia, I started looking at certain anatomic features a little bit differently once I started administering anesthesia, and so let me point out to you what's significant here. Here's another pano that's showing some significant landmarks to the lower face, which you guys have all graded one of these before. You know what you're looking for here. This is the disarticulated mandible, and here's where I want to point out to you the significance, or at least one of the significance. So the mental foramen is going to be one that you want to know where it's at. It's going to be in relation to the mental or incisive injection that we teach you about. Now, that opening, called the mental foramen, is usually between the apices of the first and second premolars. You can usually see it on the radiograph, but if a patient becomes completely edentulous, that bony landmark can change because of the resorption of the bone, and it can change to such an extent that the mental foramen is in a completely different place, so virtually on the superior border of the mandible. That's something to keep in mind, that landmark for that injection can change. So therefore, it's important to keep a lookout for it on the radiographs as well. Again, this is the disarticulated mandible. Here it's showing the mental foramen, how it's between those, the first and second premolars. It's also showing the coronoid notch right here, which is another significant landmark for the IA injection, which we're going to teach you about as well. This part is the cutaway view demonstrating the pathway of the inferior alveolar nerve, which is the yellow marker, and it shows it as it forms from a merger from the mental and incisive nerves and travels within the mandibular canal and then exits by way of the mandibular foramen. I like this picture because it shows the lateral view in the side of the face and then sort of the bony landmarks in relation. I like it because you can kind of get a visual of where that coronoid notch is. That coronoid notch is extremely important, again, for the inferior alveolar injection or the IA injection. This is actually, you're going to want to place your thumb right where the coronoid notch is, and it's going to help guide you to that inferior alveolar injection once we get there. Okay. This is the back side, or the, it actually shows the medial view of the disarticulated mandible. What I want to point out here is that mandibular foramen and how it comes out through the other side. You also have your retromolar triangle here, and there's one other thing I wanted to point out. Guess it's not on this one. But yes, keep in mind this is where the mandibular foramen is. The next part is the trigeminal ganglion, this is the gross anatomy of the trigeminal ganglion, and then the 3 divisions. So remember that there's the first division is the ophthalmic, and then maxillary, and then mandibular. So V1, V2, and V3. The 5th cranial nerve provides sensory information for all of the teeth and its associated tissues, but the ophthalmic and maxillary nerves, V1 and V2, of the sensory root, they only carry afferent nerves, and then the mandibular nerve, so V3, off the sensory root runs together with the motor root, and it carries both afferent and efferent nerves. This shows the lateral view of the cutaway of the orbit of the eye. So this is looking into V1 and the ophthalmic nerve, ophthalmic division, and then it shows how the ophthalmic kind of at this point branches off into V2 and then V3. Okay. Here is the maxillary nerve and how it branches into the oral cavity. What I want to point out here, so you have your maxillary nerve, then the zygomatic nerve and its branches. Then you have your infraorbital nerve, and that branches into the ASA and MSA. And so this is actually an injection that you can do. It's called an IO, infraorbital nerve. And if you did this injection, then it takes the place of having to do these 2 injections, which it numbs the same area, but this is just kind of the core before it spreads out into these. So if you numb this, then you're also taking care of this. However, oftentimes we do these 2 separately as well. And then the maxillary nerve branches out again into the posterior superior alveolar nerve, the greater and lesser palatine nerves, and the nasopalatine nerve, which are more injections. The posterior superior alveolar nerve is the PSA that you hear us talking about and you've read throughout your chapters. All right, so the maxillary nerve branches. This is what I was talking about. So we're looking at this second branch now. We just recently looked at the ophthalmic nerve. We're now looking at the V2, the second branch. So that V2 separates into here, right here is that posterior superior alveolar nerve that I'm talking about. And then it further goes here into the middle superior alveolar nerve. And up here, you have your anterior superior alveolar nerve. Anterior superior alveolar is going to numb, this injection, the ASA, is going to numb the anterior teeth. The middle is going to numb basically what's in the middle, so it's going to numb the premolars and then one root of the molars, and then the PSA is going to numb the molars. Okay. Oh, and then in this picture as well, you have your infraorbital nerve, which is right here. So keep in mind that infraorbital nerve, if you were to numb this, it also it takes the place of having to numb for an ASA and an MSA. All right, the lateral nasal wall is what we're looking at here. This lateral nasal wall is showing where, so you have your ophthalmic nerve, your maxillary nerve, and then your V3 here. Let's see. Kind of it gives a better picture here of how the nerve kind of branches down. And then I think in this picture, okay, so this is going to show your motor root and your sensory root. And keep in mind that we're now going to go into looking at the mandibular nerve, which is V3, and the mandibular nerve is the largest of the three divisions that form that trigeminal nerve. So one, and then 2, and then 3. Okay, ophthalmic, maxillary, mandibular, with mandibular being the largest of the three divisions. Here's the pathway for the mandibular nerve. With the mandibular nerve, the significant landmarks here is going to be that buccal nerve, which is significant because of the buccal or the long buccal injection that you're going to learn about. And then it further comes down here to show you this is where the lingual nerve is, and this is where the inferior alveolar nerve is, which whenever this is the IA injection, and whenever you do the IA injection, oftentimes you pass through the lingual nerve as well, or hit the lingual nerve, which sends a shock through the tongue. That inferior alveolar nerve comes down through here and kind of branches off. So then you have your mental nerve here and your incisal nerve, which you're going to become familiar with all of these, but right now it's just identifying the location of all of these. And then that way, whenever we're going in to further learn about them, you have an idea of where we're talking about. This picture shows the inferior alveolar nerve again, the lingual nerve in relation. It's going to also show the facial nerve here. And then how up here you have your maxillary branch again. So the facial nerve is the 7th nerve. It carries both efferent and afferent nerves. The main trunk of the nerve emerges from the skull through the stylomastoid foramen and the temporal bone. Okay. The external carotid artery supplies extracranial tissues of the head and the neck, including the oral cavity. Now the significance, okay, so the lingual artery arises from the external carotid artery, and the pathway of veins, so this figure 10-31 shows the pathway of the retromandibular vein and the external jugular vein. Here is the retromandibular vein, and this is going to be the external jugular vein, to the orbitofacial region, including the anterior jugular vein. If the needle is overinserted, so I want to point your attention towards here. If the needle during a PSA, posterior superior alveolar, those veins are right here. If the needle is overinserted, there's a possibility of piercing to this pterygoid plexus when that PSA block is administered. And when that pterygoid plexus is pierced, there's going to be a small amount of blood that escapes and enters the tissue, causing tissue tenderness, swelling, discoloration of a hematoma. What else can happen with this is, or with the PSA block, is that a spread of infection along the needle tract deep into the tissue can occur if the PSA block is incorrectly administered. And so that can involve a serious spread of infection to the cavernous venous sinus. All right, so looking at review, again, I know that this is kind of a difficult chapter to go through without a model right in front of you. I will look at videos for you, but keep in mind the maxillary bone over the facial surface of the maxillary teeth is less dense than the mandible. The mandible is more dense, meaning you may have a more difficult time achieving anesthesia in the mandible when compared to the maxilla. The median palatine raphe is a landmark for the middle superior alveolar or MSA block. The incisive foramen carries branches of the right and the left nasopalatine nerve, which is the landmark for the nasopalatine injection. The maxillary tuberosity is a landmark for the greater palatine block. The greater palatine foramen is a landmark for the greater palatine block. The mental foramen is a landmark for the mental and incisive nerve block. The alveolar process of the mandibular incisor is less dense, and the alveolar process, than the alveolar process of the mandible. And then we talked about how the coronoid notch is a landmark for the IA block. The anterior medial border of the mandible condylar neck is a landmark for the Gauge-Gates mandibular block. The mandibular foramen is a landmark for the IA block. When the inferior orbital or IO nerve is anesthetized, the ASA and MSA nerves are also anesthetized. And the MSA nerve is only present in approximately 20% of the population. Okay. In rare cases, the patient may have a bifid inferior alveolar nerve, so a second mandibular foramen may be visible radiographically. The long buccal nerve is an afferent nerve for the skin of the cheek, buccal mucous membranes, and the buccal gingival tissue of the mandibular posterior teeth. The lingual nerve is an afferent for general sensation of the body of the tongue, floor of the mouth, and lingual gingival tissue of the mandibular teeth. That nerve is the one that may be contacted when you are giving an IA injection, and that sends that shock through the tongue. The mental nerve is an afferent nerve for the chin, lower lip, labial mucosa, and the mandibular anterior teeth and premolars. And the incisive nerve is an afferent nerve for the mandibular anterior teeth and premolars. The mylohyoid nerves may serve as an afferent nerve for the mandibular first molar, but demands consideration when there's a failure for an IA block. And the last part of this, the facial nerve, passes into the parotid salivary gland, and it divides into numerous branches to supply the muscles of facial expression. Inadvertent anesthesia of the facial nerve can result in transient facial paralysis, which is the importance of the facial nerve and knowing the facial nerve. The pterygoid plexus of veins can be pierced during the PSA block, causing a hematoma. And that concludes chapter 10. If you guys have any questions, please let me know. I am free to meet with you guys. If you'd like to do that, just let me know and we can set up a review session when everybody is available to do that. Thank you.